So going on to our next case, we have genetic testing in a case of pediatric cataract, and that will be presented by Dr. Savleen. She's an associate professor at PGI, and she does a lot of pediatric ophthalmology, strabismus surgery, imaging particularly, a lot of genetics. She's published widely, and she's a member of WSPUS, APOS, and of course the other genetic societies. She's won numerous accolades as well. So I'll request Dr. Savleen to start her presentation.
Thank you so much. I'm sure we're going to learn from the audience more than we're going to present. So in a case of a pediatric cataract, its prevalence is equal to that of retinal dystrophies, and we do not talk about pediatric cataract as much we talk about retinal dystrophies. So the causes of pediatric cataract have been largely undermined in our population, I think because of that. The reason largely is because there's a lot of phenotypic heterogeneity that we see. We see different kinds of cataracts, the morphologies are not clear, they're not fitting into one particular category, and that makes it more challenging, the type of test that we have to do for these cases. So I have divided my talk into three aspects, what kind of cataract case that you see, and I'll begin with the most, I think which should not miss is that the syndromic one. So a syndromic cataract, a cataract presenting with a syndrome, it's a chance of 15% that you will see a child who is presenting with cataract to have an underlying syndrome. So a case of a 10-year female who presents with a decreased vision in the left eye along with ptosis. She has a normal birth history, and she has an asymmetric presentation of cataract. Not only is the cataract asymmetric, the cornea is also small along with the microphthalmos. You see the morphology is typical of a sutural cataract in the left eye. She also has a father who has intellectual disability with both eye low vision, and he had membranous cataract which he had never gotten operated upon. He presented to us with low vision and nystagmus and brought his daughter. The mother was normal. So now we did a pedigree, and you see a lot of males in the family having the disorder, and the child, she was a female, the sibling who was a male was normal, and the mother was normal. So the child's growth, we saw that she had low set ears, she had some intellectual disability, but the mother was not sure. She had a short stature, the cardiac hearing assessment, everything came out to be normal. She had a hemivertebra and butterfly-shaped vertebra, and the pediatrician thought that she had dental abnormalities, and this is how her teeth looked like. And when we got a dental consult, the central incisors were typical the Hutchinson incisors. If you see them, you remember them. They are screwdriver shaped and they have notches in between. You see a lot of incisors missing, and you see the lower canines are also screwdriver shaped with notches. So the radiographs also suggested taurodontism, that is the root is very small and the teeth is long. And once you combine this together, sutural cataract with dental abnormalities, you have one syndrome, that is Nance-Horan syndrome. So it is typically an X-linked disorder, and it is located, it is because of mutations in the NHS gene, which is located on the X chromosome, and it has sometimes very subtle non-ocular features, so it might go unrecognized. These are the typical features of a Nance-Horan bilateral congenital cataracts, males presenting more severely than females, sutural if you can pick them up at the right time, associated with mental retardation and dental abnormalities. So the males show more severe disease because of a hypothesis, that is the X inactivation. Some cells in the blastocyst stage get randomly inactivated X, one of the X gets, so there's a mosaicism. And you see the males have intellectual disability, bilateral cataracts, they present early, and this is how our patient presented. The carrier females have the sutural cataract, they might have subtle non-ocular features, and what was not matching was the vertebral segmentation defects in our case. We were debating as to whether we should just test for the Nance-Horan or we should, because some of the symptoms are not matching Nance-Horan. So we went ahead and did a clinical exome. We did get a mutation in the NHS, and we were lucky to pick up a large deletion in the chromosome 16, which was explaining the vertebral defects. So we did confirm it in the father, confirmed by a microarray, and then Sanger's in the father. And so it was a classical case where the dental features in cataracts was because of Nance-Horan and the segmentation defects because of deletions. So what we learned from this case is that we always examine the child and not just the eye. We are an ophthalmologist, sometimes we miss certain non-ocular features. So for instance, in this case, I always like to say be friends, because what I learned was whenever I have a child with sutural cataract, all I have to ask is to ask them to open their mouth to see, look for this abnormality. The second case is the scenario where I think again ophthalmologists should not miss, because sometimes we are fixating and people say we have to anyways operate, so why go for genetic testing in a case of isolated cataract in the eye. This child who presented a little late had a best corrected visual acuity of 20/200, had some watering, and the cornea wasn't very clear. We tried taking pictures. He seemed to be photophobic. At that point, I thought everything is normal, it's just a cataract. But when I got a peds consult, the father came up with a history of seizures, because it's a social stigma in our part of the world. Sometimes parents do not tell that the child was controlled on drugs, and he did have renal tubular acidosis. When the pediatrician told me renal tubular acidosis, I again looked at the cornea. Now I knew what I was looking for, and there was a thickened cornea. It was cataract, cornea, seizures, everything put together. It was a case of hereditary endothelial dystrophy, which I passed as normal myself. We did get an SLCA4 positive mutation, and it was running in the parents as well. The patient was put on sodium bicarb, and we took all precautions and did the cataract surgery anyway. But then deep ocular phenotyping is what I learned. It's not just the cataract, sometimes subtle findings we should be the one who should be picking up CHEDs and not the pediatrician. So I like to be friends with other subspecialties. Dr. Sonam here helped me on this case. The last category is the isolated one, where I think we have again, the question of why do we test a cataract? Again, a 7-year male presenting with decreased vision. A detailed pedigree says nobody in the family has it, but then he says, okay, the mother's sister's daughter has low vision and large family, so we screen them. We screen the mother, and then we screen the sister of the mother. Both have faint lenticular opacities. Again, reiterating that always dilate the parents of a case of an isolated cataract to look for those faint opacities that the parents might have, and both of them carrying the same variant. So we did try to see the genetic variants. It's a poster that we presented this year only in AIOS, if you like to see the results. We try to look at the morphology, try to correlate them with the variants we get. We do have the common proteins which are causing cataracts, and we somehow saw more gap junctions than crystalline mutations, and we're still following them up because we have calcified cataracts presenting to us, which might be because of a delayed presentation in our country, or are they calcified to begin with. Crystallines are by far most common. Same mutations might have the same phenotype. It might not always be the case. And sometimes you pick up unusual morphologies, and we kind of pick up a lot of collagen mutations, because they sometimes have arthropathies, so they just present with cataracts and we diagnose them to have arthropathies. Like Dr. Khan just said, we chase every pathogenic, we like to chase every VUS, because sometimes it's just VUS doesn't mean that it is not significant for us, because you have to answer parents, you have to do prenatal testing, and I think we should chase, especially in a country where we are not genotyping that much. Again, we're lucky we have Dr. Mosaji here, because I really love her article on genetics of congenital cataract. We have a large mutation rate identified in the US, UK data, and we have a lack of genetic studies in cataract particularly. And so there might be underlying mutations that we are missing, which might be life-saving for the kid. The rate of consanguinity is very high. We are a very vulnerable population, and we have to identify and report our variants, because future is the genetics. We can look at the effect of other phenotypes, like other things like myopia and glaucoma, and whether variants have a role to play with. Thank you, Dr. Jaspreet, for putting this together for us. He's a mentor for me, and thank you for all the inspiration.
Thank you, Dr. Savleen. Very nicely put across for the isolated cases, and where absolutely where the genetic testing would make a difference. So we have the expert. I mean, I've read a lot of articles from her as well. She's done a lot of work on pediatric cataract, and we'd like to have some comments from.
Thank you. I thought that was a really good talk, and you hit the points exactly. So one thing that I've noticed is that sometimes you get referrals and the ophthalmologist who's referring hasn't actually phenotyped properly, and that can just mean an ocular phenotype. You could have an adult with undiagnosed microphthalmia, or it could have subtle anterior segment dysgenesis, and then the whole wealth of the syndromic features. So history is so important. Examining the parents if you get that opportunity. I totally agree with your comment. You should try to get parental samples, and then chasing VUSs. And being friends with the family, but also maybe being friends with a lab that can sometimes push it a little bit more, who can do some functional studies for you as well. But I thought all your messages were really good. Thank you.
How do they do it there? I mean, because it's an expensive game here if you do genetic testing for the child and then for the parents as well. So it's not really possible in each and every case. So how's it there? Is it funded by the NHS? Or?
Yeah, so the good thing is, obviously, if you do the main test on the child, then segregation is usually cheaper for you here, I presume. I have to say we're very lucky in the UK. We get to do whole genome sequencing on parent-offspring trios for free on our National Health Service, so I'm totally spoiled.
Yeah, because it's very difficult to convince the child with cataract to have genetic testing and then the parents. So
yeah, basically that's what I mean. If there's a family history and you have the cataract in the family, I mean something which is not, which is like a usual cataract, probably I would not really go in for genetic testing there, but we can have Dr. Arif's comments for this, for such things.
Yeah, that was great. I missed what the last gene was, the last family. You did the screen very, but it's not important. You can tell me later. I just have two quick comments. One is that, you know, more and more with these consanguineous families, I'm seeing multiple diseases. And I think I didn't recognize it before because we didn't have access to this genetic testing. So you always have to be aware of this possibility, as you showed in your first family. Sometimes you're dealing with more than one condition, and that always has to be considered. The other thing I'll just say about the SLC4A11, sorry, the SLC4A4, there's one particular mutation in the gene that causes an ocular-only phenotype without renal tunnel acidosis. And the interesting thing about these patients is they get cataract, they get glaucoma, they also get band keratopathy, but the glaucoma doesn't respond properly to angle surgery. So this is another reason why we have to recognize these cases. If a patient like that starts having angle surgery, it's not an angle problem. The problem is the electrolytes in the aqueous. Yes. And one clue to that is they get this band keratopathy sometimes that is not related to the eye being sick. So it's just another example of why it's so important to have the proper diagnosis. It was really great cases.
Thank you.
Thank you.